Tonight's webinar is by L'Optician Thea, Canada's new leader in the preservative-free management of glaucoma, dry eye disease, and lid hygiene. Though L'Optician Thea is new to Canada, a rich history of innovation runs deep within its two founding companies. L'Optician Ophthalmics has 60 years of experience in bringing innovation to practice for eye care professionals in Canada. Laboratoire Thea, with 150 years of history in eye care, is the pioneer and leader in the development of preservative-free eye care treatments. L'Optician Thea is quickly becoming an essential partner to Canadian optometrists and ophthalmologists. For more information, visit l'optician.com. Our speaker tonight is Dr. Lori Capona. Dr. Capona founded Eye Wellness, a new concept center that brings together eye care and nutrition in 2015. She graduated from the University of Waterloo in 1998. She is the author of 3 books in the Eye Foods collection. In addition to writing numerous articles on the topic of nutrition and eye health, Dr. Capona speaks frequently about these topics to fellow doctors and the public. Her mission is to inspire and educate eye care professionals and the public about the power of ocular nutrition and prevention. Welcome, Dr. Capona.
Thank you. Good evening, everybody, and thank you for joining us tonight for this talk on eyelid management and advanced therapeutics. So tonight, we're going to explore 5 areas. We're going to talk about the challenges and applications in eyelid management. We will review eyelid and ocular surface diseases. We're going to explore the similarities between dental hygiene and eyelid hygiene. We're going to discuss the objectives and benefits of eyelid management. And lastly, we'll review related products that are available through L'Optician Ophthalmics. So everybody talks about it. In the past few years, there's been more talk about eyelid management and its role in different eye diseases. For instance, the Tear Film and Ocular Surface Society did an MGD workshop in 2013 that supported lid hygiene as an effective mainstream therapy for meibomian gland dysfunction and blepharitis. In 2014, the Cdn Guidelines promoted this as well. And finally, DEWS 2 in 2017 dedicated even more attention to the topic of lid hygiene by further discussing different product and clinical approaches, as well as including lid hygiene as the first step in their staged management and recommendations. So what are the objectives to eyelid hygiene? Why should we be promoting lid hygiene to our patients? Well, first of all, with regular lid hygiene, we can successfully remove crusts and debris from the eyelid and lashes. We can reduce or avoid bacterial colonization and thus promote improved meibum production. So what are the challenges with lid management? With this wide acceptance of eyelid management in the treatment of lid and ocular surface diseases, why are we still talking about this? Well, for one thing, even after the recommendations from DEWS and the MGD workshop and the Cdn Guidelines, we have not had any clear and universal guidelines regarding lid hygiene. And the markets have been flooded with over-the-counter and prescription products, which may have actually added more confusion and maybe underutilization of these products. Finally, perhaps the most important challenge, which we all know, is associated with poor patient compliance. And this is something that we experience in our daily practice. Okay, throughout the presentation, we're going to do some polling questions just to kind of keep everybody interactive. It's different when you're doing a webinar than when you're in a live presentation. So we're going to start with our first polling question. So the Tear Film Ocular Society 2013, the Cdn Guidelines 2014, DEWS and DEWS 2 all stated eyelid hygiene is an effective therapy for meibomian gland dysfunction and blepharitis. Do you agree or disagree? So once we have the poll results, we'll review. And 98% agree. Awesome. Sorry.
Click once on your screen. Now click one more time, it'll go down.
Okay, sorry about that technical difficulty. Now we're on to polling question number 2. So in a patient suffering from meibomian gland dysfunction, eyelid hygiene will help achieve A, healthier functional eyelids, B, improvement of meibomian gland production and tear film lipid layer, C, prevention of permanent eyelid and further corneal damages, or D, all of the above. And all of the above, 94%. Awesome. Okay. So, eyelid management is more than just the eyelid. The fact that eyelid hygiene helps to reduce bacterial colonization and improve the quality of meibum production, we can logically state that maintaining healthy eyelids will extend beyond treating lid conditions such as blepharitis and meibomianitis. Lid hygiene plays an important role also in dry eye, MGD, ocular rosacea, contact lens wearers, glaucoma patients, and also pre and post-surgical patients. So now we're going to take a brief look at the eyelid margin diseases. And we're going to start blepharitis. So on this slide, we're going to break down anterior blepharitis, posterior blepharitis, and mixed blepharitis. So anterior blepharitis is a chronic inflammation of the anterior eyelid margin and eyelashes. Its symptoms are irritation, burning, redness, itchiness of eyelids, and crusty eyelids. It's commonly associated with staph and Demodex infestation. We know that risk factors include seborrheic dermatitis, rosacea, and eczema. If left untreated, complications such as eyelid hypertrophy, including meibomian gland blockage, are possible. The main treatment for anterior blepharitis includes lid hygiene. Okay, I'm having a little bit of technical difficulty here with my screen. Cheryl, can you, oh, there we go, sorry, okay. Okay, sorry about that. Now we're gonna go to posterior blepharitis. Let me back up. Posterior blepharitis is also a chronic inflammation. I'm gonna back this up. Okay, here we go. Sorry about that. Posterior blepharitis is also a chronic inflammation, but of the inner eyelid. Symptoms are similar to those of dry eye, including irritation, burning, foreign body sensation, excessive tearing, and meibomian gland changes that lead to meibomian gland dysfunction. With posterior blepharitis, interesting enough, symptoms tend to be worse near the end of the day. And one of the main risk factors that we sometimes forget for posterior blepharitis are autoimmune disorders. If left untreated, we get fibrosis of the meibomian glands, including meibomian gland atrophy that may result. So for treatment for posterior blepharitis, we need to do lid hygiene. Mixed blepharitis is a combination of both anterior and posterior blepharitis. Now, as we know, in all of these cases, the success of therapy depends on patient compliance. So regular long-term lid hygiene is essential for optimal outcomes. And however, patient compliance is one of our biggest challenges. The next thing we're going to talk about is Demodex. And Demodex is something that we've all been treating now in the past few years in our practices. And what it is, it's the mite infestation of the eyelids that gives rise to chronic blepharitis. Symptoms include itching, burning, foreign body sensation, and lid margin crustiness and redness. Now there's two types of Demodex. There's Demodex follicularum and Demodex brevis. Demodex follicularum clusters to the root of the lashes, giving rise to anterior blepharitis. And Demodex brevis attacks the sebaceous and meibomian glands, causing MGD. Complications of untreated Demodex include blepharitis, dry eye, neovascularization of the cornea, corneal infiltrates, and even corneal scarring in severe cases. Treatment of Demodex revolves around eradicating adult mites and their offspring, including prevention of further mating to avoid infestation and thus improve the patient's symptoms. As we know, the outcome of treatment depends heavily on patient compliance with regular lid hygiene and use of tea tree oil products. So what's the prevalence and risk factors of Demodex? It's a well-known fact that the prevalence of Demodex rises with age. While the exact prevalence of Demodex remains controversial, the research has shown that about 1/3 of young adults, 50% of adults, and more than 2/3 of the elderly population are infested. In fact, a study in 2005 by Cepeda and Associates concluded that Demodex prevalence in ages 3 to 15 is about 13%. This almost triples by the age of 25 and reaches 87% by the age of 51 to 70 years. He also observed that 58% of people infected with Demodex suffer from chronic blepharitis. So why does the prevalence tend to increase with age? Well, it's been suggested that changes of the sebum composition and increased activity of sebaceous glands that occur with aging may facilitate the growth of mites in older people. Other risk factors include rosacea and environmental changes. In fact, abrupt variations in temperature and humidity may encourage mite proliferation. It is also thought that lifestyle and eating habits such as sunlight exposure, alcohol intake, smoking, hot beverages, and spicy foods may have an impact on a mite's life cycle. Now, this last photo is showing cylindrical dandruff, and this is an important finding in patients with Demodex. Gao and Associates in 2005 confirmed that lashes with cylindrical dandruff are pathognomonic for ocular Demodex infestation. So we're going to look at the life cycle and pathogenisms of Demodex. Now, the life cycle of Demodex is completed within 14 to 18 days from the egg through the larval stage, and it's followed by 5 days in the adult stage. Females may live an additional 5 days. Now, because of the short lifespan of adult mites, mating plays an important role in perpetuating Demodex infestation.
Are you still there?
By your adult mites, or by dust that contains eggs. Demodex causes problems mechanically and also by inducing inflammation. Mechanically, the mites may block the hair follicles and ducts. The exoskeleton of the mites act as a foreign body and cause a granulomatous reaction. Also, Demodex feeds on sebum and follicular and glandular epithelial cells, and this may induce inflammation of the skin and lid margin. So the debris or waste that is generated by the mites may elicit an inflammatory response. On the other side, it's also believed that mites may act as a vector to bring in common skin bacterial flora. So what is the impact in eyelids and ocular surface? What impact does Demodex have on the eyelids and ocular surface? Number one, matarosis. Demodex mites are occupying deeper regions of hair follicles, and that causes dislocation of the base of the hair. Two is trichiasis. Demodex infestation can cause the lashes to become misaligned. 3, inflammation of the skin and lid margin. Demodex feeds on sebum and follicular and glandular epithelial cells, which leads to inflammation. 4 is MGD, Demodex brevis, directly attacks the meibomian glands. And 5 is conjunctival and corneal lesions. The inflammation derived from Demodex in lashes and meibomian glands may spread over to the conjunctiva and cornea if left untreated. So now we're going to do a quick stop on dry eye disease. In 2017, DEWS 2 defined dry eye as a multifactorial disease and referred for the first time to tear film instability, hyperosmolarity, and inflammation as the core mechanisms of dry eye. The DEWS second report that was the first one in 2007, and then DEWS 2 in 2017 reinforced the previous definition of dry eye by adding how the cell damage and neural abnormalities also play a role. So let's talk about the prevalence of dry eye. Well, we know it ranges from 5 to 50%, and that's quite a range, varying depending on geographical area. We know that Asian ethnicity shows the highest prevalence among other populations. And although there's not a consensus on the prevalence of dry eye, the DEWS 2 steering committee did state in full agreement that meibomian gland dysfunction remains the leading cause of dry eye. So what are the key pathophysiological elements in dry eye? We know that there's loss of homeostasis of the tear film, an unstable tear film, hyperosmolarity, ocular surface inflammation, and neurosensory abnormalities. Now, as we all know, perhaps the most important step in dry eye diagnosis is case history and risk factor analysis. Common risk factors include age, ethnicity, smoking, excessive use of caffeine, menopause, medications, systemic diseases such as Sjogren's and autoimmune diseases, and environment. Ocular risk factors include eyelid and lacrimal system disorders, MGD, ocular surgery, long-term use of glaucoma meds, and contact lens wear. Now, we're all very familiar with the symptoms of dry eye: irritation, burning, blurry vision, fluctuating vision, foreign body sensation, tearing, ocular fatigue, ocular pain, and discomfort. However, research shows that signs and symptoms actually do not correlate well to the severity and type of the disease among individuals. But we know that the ability to accurately quantify the symptoms is an important tool in our dry eye evaluation. So thus, it's very important to use a validated questionnaire as an important part of our dry eye management. And that could be either the OSDI, the DEQ5, or the CDEA. So let's now review meibomian gland dysfunction. Healthy meibomian lipids do the following. They provide smooth optical surface for the cornea at the air-lipid interface. They reduce evaporation of the tears. They enhance the stability and distribution of the tear film. They prevent spillover of the tears from the lid margin, and they prevent tear film contamination. Meibomian lipids also seal the lid margin during sleep. Meibomian gland dysfunction is a chronic diffuse abnormality of the meibomian glands. It is characterized by terminal duct obstruction and changes in glandular secretion. It may result in alteration of the tear film, irritation, discomfort, redness, tearing, grittiness, ocular pain, inflammation, and vision fluctuations. So the pathogenesis of MGD includes obstruction, dilation, and cystic changes of the meibomian glands, and also stagnant secretion. This leads to loss of meibomian gland function with further morphological changes such as atrophy, and lastly, gland dropout. A common consequence of these changes is evaporative stress, which leads to a broad spectrum of ocular surface modification like eyelid morphological changes, decreased lubrication, increased osmolarity, ocular inflammation, and neuropathic pain. So some risk factors for MGD include age, ethnicity, again with Asian descent having the highest prevalence, hormonal changes, immune and skin diseases such as rosacea, psoriasis, Sjogren disease, medications such as antidepressants and antihistamines. We also know that environmental factors, visual tasks such as technology use, and are also related to MGD. However, it isn't clear whether these factors contribute to the development of MGD or simply make the symptoms worse. Now, rosacea is one of the big conditions that's associated with lid disease and MGD. And research shows that the majority of patients with rosacea complain of ocular symptoms. Eyelid changes represent up to 90% of cases of ocular rosacea, and anterior blepharitis is present in 50% of cases. Now, rosacea is a long-term skin condition, and it typically affects the face with redness, swelling, and dilation of superficial blood vessels. There's sebaceous gland hypertrophy and meibomian gland changes. Lid hygiene is an essential part of therapy for rosacea. So next we're going to take a look at contact lens wear and how it affects meibomian gland health. So some recent studies suggest that contact lens wear is associated with adverse changes in meibomian gland morphology and structure, as well as the condition of the lid margin and the meibum. While further research is needed to prove a direct relation between contact lens use and the impact on meibomian gland health, we should do a thorough evaluation of the meibomian glands before fitting contact lenses. And that's something that we're all doing naturally when we're checking our patients for contact lens fittings. Now, glaucoma medications. As we know, many medications used in glaucoma therapy contain preservatives, especially benzalkonium chloride. And we know that BAK can have cytotoxic effects, and the irritating nature of this can decrease ocular comfort and affect vision. In addition, the prostaglandins that we're using for glaucoma treatment themselves can also cause irritation and burning upon instillation. Over time, the built-up of cumulative effect over decades of glaucoma treatment can have an effect on the health of the ocular surface. So lastly, we're going to talk about surgical patients, pre- and post-operative patients. It's important to improve surgical outcomes, and to do that, we need to manage eyelid condition and dry eye before ocular surgery. Interesting, blepharitis has been reported in as many as 60% of patients scheduled to have cataract surgery. And we also know that blepharitis caused by Staph aureus accounted for almost 50% of infections post-LASIK in one survey. Untreated patients with any form of blepharitis, any lid disorder, MGD, or dry eye disease are at a higher risk of post-operative complications such as endophthalmitis and other infections. Okay, so we're going to do another polling question. Will you recommend the eyelid hygiene as the first-line treatment for patients diagnosed with all forms of blepharitis or rosacea, patients suffering from MGD or dry eye disease, patients experiencing contact lens intolerance, pre-op patients, LASIK and cataract, or all of the above? And most people are agreeing with all of the above. Awesome. So it looks like we're all on the same wavelength. What we need to do is figure out how we're going to get our patients to be more compliant. And we'll be talking about that a little later on. Okay, eyelid management, nutrition recommendations, and eyelid hygiene. This next area we're going to discuss is a topic that is near to my heart, nutrition. And we know that eyelid management should not be limited to lid hygiene alone. Nutrition recommendations and healthier food choices should be part of our discussion with our patients. So we're going to take some time and do a review on omega-3s and omega-6s. It's taking a minute for this slide to load. Okay, perfect. So Broadly, we're going to start with essential fatty acids. And essential fatty acids are represented by omega-3s and omega-6s, and they're necessary for normal metabolic processes. In general, our bodies do not make essential fatty acids, so we must get them from our diet. Now, looking at omega-3s include short chain and long chain fatty acids. So the short chain fatty acids are ALA, or alpha linoleic acid. And this is what we get from plants, from chia seeds, flax seeds, walnuts, and avocados. Long chain omega-3s include DHA and EPA. And these are commonly found in fish, especially salmon, sardines, rainbow trout, and mackerel. Omega-6s are represented by GLA and AA, arachidonic acid. Now, we have an abundance of omega-6s in our diets because they're found abundantly in vegetable oils. GLA is also found in blackcurrant seed oil, borage oil, and evening primrose oil. Now, the greatest health benefits from omega-3s come from DHA and EPA. Interesting is that our bodies can convert ALA, which we get from plant sources, into DHA and EPA. However, this conversion is not efficient. It's only about 2%. So that's why we often recommend for our patients to be eating fish or taking a supplement that is EPA and DHA, and we'll be talking about that a little further along. So what are the health benefits from DHA and EPA? Well, they include maintaining cardiovascular health, decreasing triglyceride levels, improved mental health and cognitive function. For ocular health, omega-3s can support meibomian gland health and tear quality and also reduce inflammation. So the most important thing regarding omega-3s in our bodies is the ratio of omega-6 and omega-3s. Now, generally, omega-6s tend to be pro-inflammatory, while omega-3s are anti-inflammatory. The ideal ratio of omega-6 to 3 in our bodies is 2:1 or 1:1. But the average North American has a ratio between 15:1 and 17:1. So how do we improve that ratio? How do we increase the amount of omega-3s in our diets? Well, the best food sources for DHA and EPA is fish. In fact, my research has shown that if you eat cold water fish 4 servings per week, you're going to receive between 850 to 1,000 milligrams per day of DHA and EPA. The fish that has the highest amount of omega-3s are salmon, sardines, rainbow trout, mackerel, and light tuna. Fish is also a good lean protein source, and it contains vitamin D, especially sardines, vitamin E, B12, and minerals such as calcium, phosphorus, selenium, and magnesium. Now, if we're educating our patients to eat more fish, we need to be aware of mercury contamination. And although there's not a hard and fast rule to follow regarding which fish are safe to eat, in general, we can know that smaller fish tend to have less contamination than larger fish. Health Canada advises that fish such as salmon, mackerel, rainbow trout, anchovy, and light tuna can be regularly consumed. However, albacore tuna, shark, and swordfish should be eaten less frequently. Sustainability is another topic that I personally consider very important to discuss with patients. We all need to be aware and concerned about our environment, endangered species, and the economic or social impact of our choices. So listed here, I have some examples of some informative websites on this topic. The one website, edf.org, actually is a great website to tell you about the safety of fish too and contamination. And they have a handy little app that tells you how many servings of each fish it's safe to eat per month and per week. So how about omega-6s? To improve our ratio, we want to increase our intake of omega-3s, but we also need to look at decreasing our intake of omega-6s. And as we've mentioned, omega-6s tend to be pro-inflammatory. So in addition to increasing our intake of omega-3s, we're going to decrease the omega-6s. Processed foods such as sweets, cakes, salad dressing, and vegetable oils are all high in omega-6. Now, I'm also going to mention here GLA. So GLA is an omega-6. However, it does have some anti-inflammatory properties, and it's been shown to help improve symptoms of dry eye when taken in the right amount. In food, we find GLA in tofu, walnuts, and peanuts. So sometimes diet just isn't enough, and we need to discuss supplementation. Of note, I always discuss diet first with my patients, and I feel that supplements, when taken, need to be taken in addition to a healthy diet. So many of us are already using omega-3 supplements as part of our eyelid and dry eye management. So what should we be looking for in an omega-3 supplement? There's so many on the market that it can be difficult to find a product that is high quality, pure, and clinically proven. So here are some guidelines that I follow. I like to use a supplement that's in triglyceride form. We know with the omega-3 supplements, we can have an ethyl ester form or a triglyceride form. When they make the fish oil, they take the oil out of the fish. It needs to get purified, at which point it becomes an ethyl ester form. And a lot of companies will stop at that. Some companies will then reesterify the omega-3 and add the triglyceride chain back on. And when that happens, it's shown that our bodies tend to absorb it better. Now, how much omega-3 should we be recommending? Well, there really isn't a standard of care for dry eye treatment yet. However, we do know that 2,000 milligrams of DHA and EPA has been shown to be effective. And if we use a ratio of 3:1, more EPA to DHA, we're seeing improvement in our patient's symptoms. Some products, some dry eye products, are also going to include GLA. However, we don't know the optimal dose of GLA or what the ratio should be with EPA to DHA to GLA. It's important that if you're using GLA, it needs to be used in conjunction with EPA and DHA. Now, keep in mind that GLA can be found in supplements such as borage oil, evening primrose oil, and black currant seed oil. Now, there's some exciting emerging research on other nutrients. Over the years, the power of different foods used by alternative medicine in treating inflammatory conditions has been studied and embraced. In fact, I find that patients in my practice are actively asking about the benefits of these foods on their ocular health. So one of them is curcumin, which is known for its anti-inflammatory and antioxidant properties, and that's the active molecule in turmeric. Green tea is also known for its anti-inflammatory and antioxidant properties and can potentially have a benefit with dry eye. And finally, the antioxidants, beta-carotene, vitamin E, C, B, D, zinc, and copper found in leafy greens and orange vegetables, fruits, and berries have shown to have some effect with dry eye treatment. Okay, so we're going to do another polling question. Diet and lifestyle changes should be part of your patient consultation. Select if you agree or disagree. And 97% agree, yay. Okay, and one more question. Omega-3 supplementation in conjunction with eyelid scrubs and warming masks helps to improve dry eye signs and symptoms. Agree or disagree? And 99% agree. Great. Okay, so we're going to review the benefits to eyelid hygiene. What are the benefits of proper eyelid management? So one, lid hygiene plays an essential role in the prevention of lid and ocular diseases. It improves the quality of the tear film, which ensures a well-protected ocular surface. This results in enhanced visual acuity and better treatment outcomes for ocular surface disease. It helps prevent permanent lid and corneal damage, and also lid hygiene has a positive impact on surgical outcomes and may help to prevent post-operative complications. So we all agree about the benefits to lid hygiene and management. How can we increase compliance with our patients? Well, recently there's been comparisons between dental hygiene, which is widely accepted and practiced, to eyelid care. We all know the benefits of brushing teeth and flossing on oral health, and everyone has periodic visits with their dental hygienists. Dental hygienists routinely perform screenings, they assess risk factors, they perform a thorough cleaning, and usually discuss home care and new products. This model of dental hygiene has led to better dental care and healthier, more satisfied patients. So this question is, can we apply a similar model for eye care, particularly for lid management? Perhaps we can achieve this by including screening for lid disease and dry eye. We can do debridement in office, or we could do warm compresses followed by meibomian gland expression in office. We can include patient education regarding warm compresses and at-home lid hygiene, and we can educate our patient about the products available. So what does an at-home eyelid hygiene look like? Now, depending on the individual treatment plan, it could include warming masks, lid massage, lid cleansing, and artificial tears. Warming masks work best when they are on for at least 10 to 20 minutes, which is what we've been practicing. As far as eyelid massage, proper techniques are debatable. However, many clinicians recommend extending the finger and applying light pressure, as shown in the picture, rolling the finger upward on the lower lid twice while in up gaze and downward on the upper lid twice while in down gaze. Another thing you can do is in-office expression of meibomian glands. In my office, I do this using a Mastrada paddle after warm compresses. Now, one thing to note is that excessive manipulation of the lids can actually cause additional irritation. So more is not always better. So we don't want to be expressing those glands too much. After you've done an effective massage, eyelid cleansing is important. So cleansing techniques consist of using repetitive horizontal motion along the index of the eyelid for about 30 to 60 seconds, followed by a facial rinse with water. And there's so many products available to do this. But what we need to remember is that soap and mild detergents can have a negative effect on the ocular surface and on the tear film. In fact, baby shampoo has been shown to have a damaging effect to the goblet cells. So we need to be looking for products that are preservative-free and hypoallergenic, and we're starting to have access to many of these products. After regular lid hygiene, installation of artificial tears is often recommended. Now, we've all given our patients these recommendations in the past, and we know that compliance has been our biggest hurdle. And maybe if we can put on our thinking caps and use a dental hygiene model, we may be able to get more compliance from our patients. So let's talk about eyelid cleansing. What are the properties we need to look for an ideal eyelid cleanser? So suitable eyelid cleansers should be effective in removing lid crusts. However, they should also be gentle on the eye. They have to be comfortable for the patient to use, so we increase compliance. We want to choose products that are preservative-free, paraben-free, and perfume-free, and this may also help to increase compliance. Okay, so we're going to do another polling question. Eyelid warming, lid massage, and cleansing are all essential steps for proper and efficient lid hygiene. Agree or disagree? And 98% agree. Awesome. Okay, so let's look at some in-office treatment products that are available through Labtician Ophthalmics. One of their in-office products is called Blepharitis, the Blepharitis eyelid applicator. So this is an in-office debridement of blepharitis and Demodex. It contains tea tree oil, coconut oil, and it's free of any preservatives. It's simple. It has an easy in-office application. What we do is we mechanically remove debris and crusts from the eyelid. It cleanses the cylindrical dandruff from the lash root, and it stimulates embedded mites to migrate out of the skin. So at the same time, what's happening is it's enabling the tea tree oil that we're applying at home to reach the follicles and the sebaceous glands. We get symptom relief by reducing the debris, but also by stimulating meibomian gland secretion. It's cost effective, and anesthetic isn't required when we're doing it in office. Other in-office therapeutic devices that can be used for lid treatment, lid management, are MiboThermoflow, Ilux, and LipiFlow. And some of us have already been using these or have, been working with optometrists or ophthalmologists that are using some of these in their practice. All of these function based on eyelid warming to facilitate the release of secretions from the obstructive meibomian glands by giving gentle but firm pressure on the eyelids. So currently, there's a wide variety of at-home use products through Labtician. This slide is showing some of the products that they have available. So they have creams and gels, wipes, foams, masks, goggles, as you can see. One of the things that Labtician prides themselves on is having products that are cost-effective, user-friendly, and clinically proven. So there's the eyelid mask here, which is a self-activated mask upon exposure to air. It's safe, comfortable, and provides a controlled and consistent heat source of 43 degrees plus or minus 3 degrees Celsius for 10 minutes. The Brochure mask, which many of us are familiar with already, is another safe and comfortable reusable warming mask. Blephagel is a sterile and preservative-free gel that contains no parabens or perfumes, and it's safe to use daily. It's actually applied onto the lid margin and not washed off. Blephaclean is an antimicrobial, sterile, and preservative-free wipes. They have no parabens or perfumes, and they are also approved to be used daily for cleansing of the lids and lashes in cases of anterior blepharitis. Now, Blepharitis wipes and foam are antimicrobial and bacterial, also antifungal and anti-inflammatory, and it's suitable for daily lid hygiene in patients with Demodex. They're all natural and preservative-free, and they contain tea tree oil and coconut oil. Now, there's artificial tears, preservative-free, multi-dose, including Hybac, Theolaz, and Theolaz Duo. And Labtician also carries the PRN omega-3 supplements, both liquid and capsules, which are in triglyceride form. Okay, we're going to do another polling question. So both in-office and at-home lid management are equally important for ensuring the success of your recommended therapy. Agree or disagree? And 92% agree. Awesome. Okay, management of anterior blepharitis. So, Labtician has prepared a number of in-office and patient information materials based on the most recent guidelines. Now, I believe that every patient has an individual treatment plan, but sometimes these pre-made little brochures are going to help us. They may fit what we're recommending our patient. So this one that's available talks about management of anterior blepharitis. So it's giving information on Blephaclean and Blephagel and also Blepharitis. There's management of posterior blepharitis or MGD. For example, you can use an Eyegene mask or Brochure mask, and also supplementation with omega-3s. Okay, we're going to do another polling question. If a patient presents with anterior blepharitis, beside prescription meds, should you recommend and perform an in-office lid scrub? So select one of the following: yes, only if it's a severe case, no, or not sure. And most people are saying yes, with 63%, 30% only if it's a severe case. And I would say that that's pretty good. It also depends if you're set up for it in your practice. Okay, next polling question. For lid management in your practice, will you consider to adopt a similar model to that of dental hygiene? Surely, maybe, or not at this time. So it looks like we're split on this one. Most people, 42% saying for sure and 48% maybe. And I think that's great because at least we're starting to think about it. We have to, I believe that we have to do something to help improve our patient compliance, and this may be a way that we can get that to happen. Okay. One other thing that Laptician has done is they've recognized the importance of patient education, and their mission is not only to assist clinicians, but to affect change in the patient's quality of life as well. So here's a simple, helpful guide that they've created based on actual guidelines. To giving patients examples on how to warm their lids using their warm compresses, how to do the lid massage, eyelid cleansing, instilling tears. And I find that any type of educational material is helpful in my practice. So this is something that may be helpful in your practice as well. Okay, one last polling question, and then we're going to be coming to the end of our webinar. We're just going to get this polling question loaded. Will you consider asking your sales rep for more information about lid management, in-office and home use products, or for a patient brochure? Surely, maybe, I don't need more information, or I prefer to seek assistance from other independent sources. Okay, great. So 58% will, 26% may. I think it's they have a lot of great information, and I know that in my practice we carry many different types of artificial tears and many different types of products to help with our eyelid and dry eye management. And I just know it's an area that keeps growing. So I think that's awesome. Okay, let's do a review. Key takeaways. As a quick recap, similar to dental hygiene, eyelid management must include proper screening and risk assessment, in-office debridement and treatment, patient education and coaching, followed by regular at-home lid care. Compliance is of utmost importance, and it remains our biggest challenge as clinicians. When we consider the benefits of eyelid management, we should look forward and develop ways to help increase our patient compliance, thus improving our care of our patients and of their ocular surface disease, and also help with surgical outcomes. We can start with small steps, perhaps by trying to design a simple but efficient protocol that we can use in office and one that we can give to patients to be using at home. We have also seen during this webinar tonight that there is full access to effective and safe products that are gentle on the eye, patient-friendly, cost-effective, and clinically proven. I know that my lid management, that part of my practice, is continuously evolving, and I already feel that I'm able to provide better care to my patients. I'm excited to grow this part of my practice and to reap the benefits both for the patient health and for the health of my practice. Okay, and that brings us to the end of our webinar. So thank you.
We'll now share the questions you've submitted with Dr. Capona. Dr. Capona, do you offer in-office lid management in your clinic? And if so, can you describe how you integrate it in your practice?
Okay, so in my practice, currently, as I had mentioned, my dry eye program is continuously evolving. So right now we do an in-office lid treatment. And what we do, for patients that I believe are going to benefit, I will schedule one of these treatments. And we do a warm compress for about 15 minutes in the office. Then I do expression of the meibomian glands with the Mastrada paddle, followed by a lid cleansing, a lid hygiene, and installation of whichever artificial teardrop I feel is going to be beneficial to them. Interesting, when we started this procedure, is people were calling within the week saying that they were noticing such an improvement in their symptoms. And we have a core group of patients that are coming in every 3 to 4 months to have their glands expressed, and they keep coming in, and it's been a great treatment that we're doing. One of the things we do to make it really enjoyable as well is we put on spa music, we put a diffuser with nice essential oils, and we try to make it a spa-like treatment for the patients also.
Thank you. Another question, do you retail artificial tears, eye masks, and other dry eye and lid management products in your office? And is it well received by your patients?
This is something that I've started doing in my new practice at Eye Wellness. And we actually retail most, I would say 99% of what we are recommending for our lid management and our dry eye treatments. Masks, lid hygiene, eye drops. And it's been very well received because it's more convenient for the patients to get them from us, and they end up, leaving with their packet of products that they need. So yes, we do, and it's something that I highly recommend, and I'm very happy that we've started doing that.
Thank you. We have a few more questions here. If you have a patient who can't use a brooder mask because they don't have a microwave, what do you recommend for them to use for hot compresses?
There are other masks that we can use. They're not as effective as the brooder mask, but there's other ones that you can put into hot water to heat up. So we have those. There's also that one mask by Laptician, which I haven't used yet, which is that self-activating heating one that you can ask your rep about. And sometimes, this is kind of an old-fashioned way, but it makes sense. I've had a patient that's used a thermos, filled it with hot water, and put washcloths, warm, wet washcloths in there and alternated it. So when the one on their face got cool, they would take the one out of the thermos and use that. So that's kind of like an old-fashioned way to do it without the microwave.
Great, thank you. We have another question. What about those patients on a vegetarian diet? How can they improve their EPA, DHA intake without eating fish?
Okay, and this is a very common question that I encounter. So when you have somebody that's not eating fish, it's going to be very hard to get the EPA and DHA levels high enough without a supplement. So through food, we're going to want to eat foods high in ALA. So flaxseed, chia seed, hemp seed, walnuts, avocado. If they're strict vegan and they're not eating eggs, then don't recommend the eggs. But some vegetarians will eat eggs, and if they do, recommend that they buy the omega-3 eggs that have DHA. Also algae, so the nori that is around sushi has DHA in it. Finally, there are vegan omega-3 supplements that you can find, and I do recommend those to most patients that are following a plant-based diet.
Thank you. Another question, when do you choose Blephagel over Blephaclean? Or what are you looking for in the lids prior to choosing the best option for your patients?
So for me, when I choose between the two, Blephagel I use more as a maintenance, somebody with meibomian gland dysfunction, not a lot of actual dandruff, you know, or the blepharitis on their lashes. The Blephagel works well for patients without that. If there's active blepharitis and a lot of debris there, then I would recommend the Blephaclean.
Okay, thanks. Looking at another question here. Is the Blephagel product antimicrobial and or anti-inflammatory?
It's antimicrobial. I'm not sure about the anti-inflammatory part, the Blephagel.
Okay. And I think that's all the questions we have. So this time I'd like to thank Dr. Capona for this insightful presentation and Labtician for partnering with OAO for tonight's webinar.